Hello, I'm happy to continue this webinar on trying to answer the question, do more HMOs translate to increased benefits? So that's the layout of my presentation. And of course, everything starts with breastfeeding. And is HMO really a new topic? Well, in fact, no, because we know since 120 years that mother's milk has unidentified carbohydrate fraction, which is important. And since 1930, we know that there is a bifidogenic factor in human milk, which consists of oligosaccharides. And we know since 70 years that those abundant oligosaccharides, their structure has been discovered. So the only aspect which is new is that since a couple of years, we can make those human milk oligosaccharides artificially, but with exactly the same structure as with which they are present in mother's milk. And that's important because oligosaccharides are the third most important component in mother's milk. And as you already heard, there are different categories of those human milk oligosaccharides. There are the non-fucosylated one, there are the fucosylated ones, which are probably the most important in secretor mothers, and there are the sialyllated ones. And the composition of mother's milk in HMOs differs depending on the fact if the mother is a secretor or a non-secretor. And that mainly has an impact on the amount of 2FL as illustrated in these slides, where the amount of 2FL is quite high in secretor mothers and virtually absent in non-secretor mothers. It also shows you at the same time that the amount of HMO present in mother's milk differs from region to region in the world. So what are the benefits of HMOs? What do we know about HMOs and their immune and cognitive outcomes? Well, first, let's focus a couple of moments on infectious disease. This is in exclusively breastfed infants, where it has been shown that infants from a mother which is a secretor is better protected for Campylobacter diarrhea and all causes than diarrhea than an infant from a mother which is a non-secretor. And the same can be said for atopic disease, for atopic dermatitis. An infant, an exclusively breastfed infant from a mother which is a secretor, has a 3 times lower risk to develop atopic dermatitis than an exclusively breastfed infant from a non-secretor mother. And the amount of 2FL has also impact with cognitive development. So what this slide shows you is that the amount of 2FL in breast milk at the age of 1 month is associated with a better infant cognitive development at 2 years of age. And 3SL, another HMO in breast milk, is positively associated with language development in early childhood. So those HMOs not only protect for infectious disease, for allergic disease, but also for cognitive development. And what about the HMOs which we add to infant formula, mainly 2FL and LNNT? What has been shown for these HMOs is that if you provide them to the infant up to the age of 6 months, that they protect the child for development of infectious disease up to the age of 1 year. So there is a decrease of infections. There is a decrease of antibiotic use up to the age of 12 months. And those human milk oligosaccharides can be related to the fecal community and which can be related to the requirement of antibiotics. In other words, what this slide shows you is that the fecal community, the gastrointestinal microbiome in infants fed those 2 HMOs is much closer to the fecal community of the breastfed infant than in test formula, which was not supplemented with HMOs. And if you relate that to the need for the infants to need antibiotics, then it shows you that when you add infant HMOs to infant formula that you decrease significantly the use, the need for the use of antibiotic, and that's related to the composition of that fecal community. So previously reported low rates of infections-related medication use with HMOs may therefore be linked to the gut microbiota community types. So addition of HMOs does have health benefits. And what about 2 HMOs added to extensive hydrolysates in infant with cow's milk allergy? What has been shown is that infants with cow's milk allergy, which have an increased risk to develop infectious disease, when they get an extensive hydrolysate supplemented with those 2 HMOs, 2FL and LNNT, that they have a decreased risk for the need of antibiotics and a trend to a decreased risk of antibiotics, of antipyretics. But so the decrease in antibiotics is absolutely clear. Now, what about use of those 2 HMOs in the preterm infant? This is a new trial where the 2FL and LNNT have been added in a liquid way to the feeding of preterms compared to control, which contained glucose as placebo. So what was the outcome? Well, the primary outcome was looking at the duration needed for full enteral feeding. So the time needed for full enteral feeding in the HMO group was 12.2 days in the total group, and for placebo, 14.3 days, which means a difference of 2 days. So preterm infants which receiving HMOs achieved full enteral feeding 2 days earlier than those which were given placebo. And that's related to an overall length for age z-scores through the entire full enteral feeding period until discharge, which was marginally significantly higher in the HMO group. And that's also related to head circumference for age scores, which were significantly higher in the HMO versus the placebo group at hospital discharge. So HMO supplementation is clinically proven to be safe and well tolerated in preterm infants, as evidenced by reduction of time to reach full enteral feeding by 2 days. And HMO supplementation, when given as soon as possible after birth, supports age-appropriate z-scores in length and head circumference according to preterm growth standards, indicating that HMO supplementation may support improved early postnatal growth. And that effect is seen as early as first 3 weeks of supplementation. And what about the future? Even more HMOs for healthy infants. So there are now data of a clinical trial with 5 HMOs added to infant formula, 2FL, DFL, LNT, 3SL, 6SL were added to infant formula. So the overall purpose of this study was to evaluate growth, safety and tolerance in infants fed in infant formula with 5 HMOs. And this is for the first time a study that follows those children up to toddlerhood, up to the age of 15 months. So those infants were giving the HMOs up to the age of 1 year with starter infant formula, with follow-up formula, and then they were even followed with those HMOs into toddlerhood. So the supplementation was much longer. And what do the data show us? Well, it shows that this new clinical trial with that infant formula with 5 HMOs supports age-appropriate growth, and that it is safe and well tolerated up to 4 months of age. And the stool frequency and consistency were similar between formula-fed groups and indicated soft stooling pattern as in breastfed infants, with over 65% of the formula-fed and breastfed infants having predominantly loose stools throughout the study. So what are the take-home messages? HMOs are structures can be made with identical structures as the oligosaccharides in human milk. They are safe, and normal growth and tolerance has been shown in term and preterm infants and in infants with cow's milk allergy. And what has also been shown is a reduced risk for infectious disease in those infants with got infant formula with supplementation of those two HMOs. And now there are data that we can already add 5 HMOs to infant formula. And so we are looking forward to have the long-term outcome of those new clinical trials. I thank you for your attention.